is a clinician researcher at the MUHC and assistant professor in the Department of Psychiatry at McGill University. She obtained her BSc at the University of Toronto, MD at University of Saskatchewan, MSc in Psychiatry specialty at McGill University, and a clinical research fellowship in the section on developmental genetic epidemiology of mood and anxiety program at the NIMH in Bethesda, Maryland, USA. She is American Board certified in psychiatry and has won Junior Investigator Awards from the Society of Biological Psychiatry, International Society of Psychiatric Genetics, the American Psychiatric Association, in addition to funding from the MUHC Research Foundation. She is a Chercheur Boursier Clinicienne, salary awards recipient from the Fonds de Recherche en Santé du Québec. So without further ado, welcome Nancy.
Hi, everybody. Okay, let's see here. Okay, so I have the task. If I'm not speaking loud enough, just signal somehow, and I'll speak close to the mic. So I have this task of trying to summarize and maybe kind of provide some perspective on each of the different talks today that really are in a way inspirational in terms of everybody's idea of trying to develop e-mental health tools. I think it falls under that large category. And I really think a lot of congratulations should be given to each of our each of our speakers today. I have a bit of experience in this area, and I'm going to speak to that. I'll summarize it a tiny bit. So this is just to say that, I think most people here are working in mental health and are touched by it in some way, shape, or form. And so in general, I'd like to think of things going from when you first begin having symptoms, or you're undergoing a loss in your life, or a change in your life, a modification of your environment. And it just begins with symptoms which are just omnipresent. Everybody's experiences those, they're just part of life. The symptoms then can become more frequent, more intense, more interfering in your other aspects of your daily life, so your work, your occupation, your friends, your family, and then that may actually lead to a diagnosis and then treatment. So this is kind of what we want to tackle as mental health professionals. We want to kind of address these things. And there has been essentially different interventions or things to be able to monitor this or view it in general. So at the symptom level, it's mainly outreach, so education, monitoring, outreach. And then if you're thinking that someone could be impaired and they might meet a disorder criteria, you want to do some screening. And then actually after they have a diagnosis, you actually give treatment. So these are kind of mental health or public health and kind of medical approaches to be able to address this continuum. And there's been traditional methods that have been used for that. Things that everybody knows, so just for education, you do tabling events, you do pamphlets, you do workshops, you do psychoeducation, try to get this information to everybody broadly. It's for everybody to know. And then for screening, typically you do paper and pencil, right? You send them a questionnaire, or you get them to get screening at their family physician office or any kind of area where there's public health. And then once they get a disorder, you do treatment. And so then these all provide opportunities for e-mental health kind of delivery of these types of interventions. So maybe the first one that Phyllis had spoken about, more related to outreach at this point, at where she's at in this research. So developing a website for that, converting it into a mobile version as well. Nobody talked too much about the screening part of it because both Mark and David are at the point where people are actually diagnosed, so they have a diagnosis, and you're doing symptom monitoring, or you're doing kind of actual explanatory feedback about the mechanism, about why they may feel the way they feel. So these are the two areas that were kind of targeted today, outreach and then actual treatment. So that's kind of how you can see an overview of how these e-mental health approaches could be useful. And it's just going to be necessary to go this approach. I think it's necessary, along with the idea that just with the internet and technology, everybody knows everything. A lot of times they don't know things that are really relevant, like what Phyllis was pointing out in terms of the source of that website. What they use is not accurate, or it needs to be more evidence, or it needs to be vetted by a healthcare professional. That's what people are really looking for. You just have this like flood of information, and you don't really know how to discern whether it's accurate or not. And I think that consumers or clients are really looking for that part. So if you have something that people can really rely on, that's why for the app that Mark was talking about, he wants, like, they really want communication with healthcare professional. They want that kind of, link to be made. So essentially, mental health conditions are costing society a lot. They estimate from 2011 to 2030, it's going to be about $16 trillion. And the burden of mental health is actually, it's really increasing, especially for depression. And essentially, the demand is so high now that we just won't be able to deliver any more gold standard treatment. That's just not going to be feasible, given the kind of the rapid, increase in symptoms and impairment, and how much it costs for society to train somebody to be able to do those things. The cost of, putting someone through like undergrad, a more formal healthcare professional training, it's really costly. And then that delivery, there's a really long lineup for that part. So there's been a shift to actually use people who are less trained, less formally trained, but more highly experienced. So a focus on lived experience, a focus on peer support. So treatment is shifting towards those kinds of professionals delivering the treatment. And self-care is one of those big parts as well. And that's how also treatment apps can be really useful for promoting and empowering self-care, increasing their understanding of the illness and their personal kind of pathways for them to have distress. And it's, I think I would say that it's very suitable. It's very suitable in terms of matching what you want to deliver and what the client needs, because there's such wide coverage of wireless technology, there's such wide coverage. Because of we talked about, like, if it's stigmatized, and you can actually have this mobile app that you could be looking for online shopping, you could be looking at your depression score, you could be looking at, any kind of your HIV status, you could be looking at those things. It's private. That's why I think people really also like the mobile app part of it versus sitting at a computer and having to be confined to a specific location. So it's portable, it's private, it's accessible to direct communication. So because like many clients want access to the healthcare professional, it provides information, and it really supports self-care, not just in an individual way with your healthcare clinician, but also with other peer supporters and also others with lived experience. That's a really big component of it. It empowers the users, and it really maintains their autonomy in the whole process. And so these were just like potential, kind of possibilities for use of healthcare technology, increasing adherence to treatment. Compliance is always a very big issue with, clients uptaking the treatment. Public awareness campaigns, workforce training, record keeping, symptom monitoring, self-management tools used in decision-making for clinicians. We often don't talk about that too much, but there are a lot of apps for clinicians to help them know what antibiotics to do, what's the most recent algorithm to help them guide that part. So there's a focus on clinicians as well in order for them to use apps, self-guided interventions. And so in terms of kind of the stages of, taking an idea, thinking about it a lot, and having it go to implementation, almost everybody who thinks about kind of going down this path goes through this. So the first part is inspiration. And I would say most of it is driven by either the patient needs or the clinician needs, one of those two stakeholders in it. I would say lots of times it's from clinicians hearing patient stories. That's a really big component of why people have ideas about, I need to, I have a really great idea, I want to make it more efficient. I'm always having this need expressed through my patient contacts, through the family contacts, and I want to get it addressed. So generally, that's the major driver for it, patient experience, clinical experience. And then it happens this phase of ideation. So and I think that like you've gone through this a little bit where you're actually getting like kind of multiple stakeholders' feedback about it, not just your individual understanding of what the problem is and what the need is, because oftentimes it's essentially you think that the patient needs this and the patient tells you you need this kind of thing. Like I've noticed that it's really a very, it's not always at all the same like kind of target. So they think that you need to be more organized, and you think that they need to follow your instructions better, or something like this. So it's often really like a missed intersection. So that's very critical, and I want to say that to collect every person in the whole process, their feedback at every stage of your kind of implementation and ideation phase of it is really critical. I think that and also for that. Stakeholder group to be representative. That's very important as well, because really people really like to be heard, but as well, it needs, lots of people don't say what they need, and I think it's important to systematically ask as well, because there could be kind of a need that you're not addressing that a lot of people are experiencing, that they maybe because it's stigmatized or they don't necessarily want to, like for example, that they don't like their healthcare clinician. That's a common thing, and so if you can help facilitate even like giving the feedback to the clinician about that in kind of a neutral way, that would also be very useful for them. So the ideation phase is really thinking a lot about your idea, trying to refine it, trying to get other perspectives on it, seeing if it's done already, and finding experts and guidance. I think that as like healthcare clinicians, we are like very competent at what our training is, but we're not really competent at all the other disciplines that are actually really required for a successful e-mental health tool. Like we're generally the substantive experts. That's generally what we are. But we're not experts at design or understanding technology or security, that kind of thing. We can kind of get a taste for it for sure, but I think it's very important to engage other experts in this area because there just really clearly are experts at it that have spent as many years as we have trying to learn about clinicians' or patients' problems. So it's very important to find experts and like understand and kind of hear their guidance on it, and also to be discerning about that as well, to know, because when you go into kind of an area that you're not aware of, you have to really see if there's other kind of interests there as well that may not be necessarily your interest, right? So you have to kind of develop a new skill set in terms of discerning other kind of areas of expertise. And so you really ideally want to reduce your inspiration to something that's measurable and objective, very similar to research. You want to reduce it to that, and then try to set out a set of objectives that you want to try to achieve and then measure. You ideally wish to do that. So you're applying a more rigorous approach to an idea that's more like inspirational to begin with. And I see that like everybody's at different phases of implementation. And the implementation really, that part is really nuts and bolts. It's like maybe not the most inspiring or creative part of it, but it can be as well when you talk about, say, user experience or how the app should look, how the website should look. That's a creative part, but that's really like the design experts that can help you on that, as well as user experience or user feedback helping you with that part. And it really, I want to emphasize that it's really iterative. You can see that even in your own experiences so far, it's really iterative. You get a feedback from somebody, you want to incorporate it, you send it out again. So that's why they have like version 4.0, 4.25, 4.6, this kind of thing, because it's really an iterative process. And kind of build that into your kind of, project. Don't think that, oh yes, like, version 2 is going to be perfect. No, it's going to keep on adapting. That's what's going to, occur. So in terms of, you have to really, in terms of the things to do this part, right, you have to really know your target population. That's why doing all the stakeholder feedback, getting focus groups, those are really, really critical. And not just the person that you're going to be treating, but really everybody in it, like the nurse, the frontline staff, the person who's doing the billing, all these people, you really have to do like a kind of at least a focus group, if not more, in terms of constantly getting their feedback on it. And I want to say they will give their feedback if you actually listen to it and incorporate some of their feedback as well. Give them feedback about what you've learned. So the target population, the treatment team, I think it's really, like, this was a major issue when we were trying to engage in this, is like having the patient be reassured that their information was going to be kept private and that there would be different components of the app that they could let their family see, let their friends see, let their healthcare professionals see, that even if they sometimes were suicidal, they would have the decision to be able to disclose that, because they won't put that on an app if they think that it's going to be everybody can have access to it. So those are concerns that they really have, which are very, very valid. Just think about it for banking, or think about anything that you do online, how like kind of very vigilant you become with that type of information, and this is really personal health information. So be always aware of like what their concerns may be, and there may be concerns that you never even thought of, that you know that they're concerned with. So if someone picks it up, someone knows their password, all this kind of stuff. They just want to know what happens with that information. Where is it stored? And then Mark talked about this, about validating it. So once you begin collecting information, what's the means of it? What are you going to do with it? You got a big like data dump. What are you going to do? How are you going to kind of not just let it sit in cupboards? You're going to have to like process it. And how you're going to modify whatever your intervention is as a result of that. And then you repeat after that. So that's the implementation phase. And these are just like some tips from essentially people who have engaged in not using e-mental health tools, but just like trying to be successful, like selling something online or converting something to an app. Is that in general, they don't do many things. In general, those who are successful do one thing, but they do that one thing very, very successfully. So you have to kind of focus on the one thing. You do it really, really well. So you focus on like just the communications part, or just like specifying a reminder for medications or compliance or whatever it is. So among all the needs that you have and your clinician and your patients have, focus on something that is out there that's not being done well. Like some people do it like when they wait in the waiting room at the emergency room, or waiting at a restaurant. So all these things, there's lots of different types of technology that can be applied to it. So focus on one thing. Don't try to do everything, and try to really excel at that one thing. That's what people who have been successful in developing apps do. Deliver what people want. So that's not just what you want, what they want. And it really helps promote, and generally I would say in mental health care, it's really promoting their autonomy, promoting their ability to be able to modify what it is, like in your very refined study, how they can actually use that information that they've given to actually improve longer times with good mood. And innovations are taken up generally if they're specific. And they usually, so something's very onerous for time, like making appointments. That's a very onerous, when you want to make an appointment with your doctor or with anyone, your physio, it's really onerous. You have to call, you have to leave messages, you have to go back and forth. That's why people like to use email. That's why they like to use a scheduling system. So something that is like heavy with respect to burden and time and hassle, but actually very useful for the patient. So that's kind of what you want to target, something like that. And those that have been successful really kind of take those things into consideration. They really ease people's lives, don't create like more daily stress, essentially. Okay, so I'm just going to go through a couple slides that talk about we developed an app for young adults. It's really adults in general for depression. And I'm going to go through it, then I'm going to talk about all the pitfalls, and then maybe give you some hope too. So essentially, we designed an app, and it was for young adults associated, diagnosed with depression, so it's in that category of already for people who need therapy. They could be receiving medications, they could be getting CBT. And the objectives were really that it provide guidance for the depression treatment once it's already been given. So you're the clinician, or the psychiatrist, the psychologist, the social worker, you're giving advice for behavioral modification or some type of monitoring or medications, and then the patient leaves. And then you want them to increase their self-awareness for monitoring their own symptoms, and then you want to increase their self-care. So that was the objective of it. This is like nice slides related to when I had to pitch it for kind of funders. So it was called On Track, and we found out later that On Track that name is for people. There's an app that's for diabetes. So that name couldn't even be used, but we just thought about that, and then we're like, oh, we'll just call it that, right? But then when you go and search online and you do all this research, it's already been taken up. And it was like really, like you have to try to say like in one sentence what your app or what your kind of, tool does. So ours was really accelerating depression care between appointments. That's what it was supposed to be doing. And so this was just say that depression is very prevalent. It's very common. There's a lot of people who suffer greatly from it, especially young adults. It's a really big cause of disability in the workforce. And so generally at the first appointment, the patient and the clinician would be sitting there, and they'll be saying these are the ideal treatments for depression: medications, tracking your mood, and giving you activities you should be doing, behavioral modification essentially, or increasing behavioral activation. So those are things, those are kind of the 3 gold standard things that you give. But in between, the patient kind of gets lost, because remember, they have a lot of symptoms, they have a lot of impairment, and they kind of don't uptake the majority of what you say to them. So it would be really good if we could find a way for them to actually be reminded of those things. And so if a person doesn't uptake the treatment, quickly, if they follow treatment and adhere to those things, they can recover probably within 3 months. But if they don't, they can fall off to 6 months, which is a really big deal for somebody losing potentially 6 months. Okay, so then the app was really a combination of the ideal treatments for depression plus contact with the clinician. So this was a big component that we also thought as well, because a lot of patients want contact with a clinician, and they just feel like that even though that seems like a very simple thing, like just getting one text message from your clinician can be so reassuring to the individual, or having one feedback that says, yes, you're on the right track, or no, you're not on the right track. Like having a side effect that they don't know what to do with, and they have to wait a month before they can see their, physician. It's really a long time to wait, and then your mind can just go, especially if you're already thinking negatively, can just, run away with you. So that's why that contact, we've realized, was a very crucial thing. But introducing contact with your healthcare clinician introduces a lot of other things as well. So this app was supposed to kind of create this little circle that you'd be able to, have this continuous. So this is an overview of what the app looked like. This was the care options in it. So the depression care. So it had psychoeducation in it, medication, scheduling, and journal. There are scores, resources for them. So the schedule involved checking in, using the app, thoughts, so that's the negative thoughts, getting help if you needed it, and what their journal was like. So, and these are kind of more behavioral activation things, and then if you needed more. So I'm just gonna go through some of the screenshots about this. So medication reminders, telling you to take your medication every day, the prescription, the actual prescription of what it was, and if there was side effects from it as well, and you could input side effects as well. Have you taken your medications? Did you have side effects? And schedule. So for CBT, for depression, you want to have an activity, kind of an activity log. You want them to be able to kind of fill these in and track their mood. So all of these things were you able to do within the app. And then giving them a treatment team, so their therapist, a case coordinator, peer supporter, text messaging, and then kind of other resources if they needed it. This was just going a little bit into their scores, summarizing them. And then this was the clinician side of it. Clinician side of it. I'll just skip through these. We didn't focus as much on the clinician, we were focusing on the patient at the time, but the clinicians also had said they want a mobile version of it, because at the beginning we just thought the clinician would be sitting at their computer doing this, during their office hours, but actually the physician said they would prefer a mobile version of it as well. So that had to be developed. So anyway, these were all kind of alerts. If they wanted to set an alert for a certain patient, if their depression level a certain number, they would want that. And the user would have to agree to that kind of alert being that the physician would know that as well. So compliance. So anyway, that was the app that we had developed. And so that was meant to enhance patient wellness, to increase the recovery quickly of the patient, and increase the capacity, so that lots of times when your patient comes in, they're only at stage 1 of the treatment, just beginning medications, when they could have been 6 weeks later already at a good level of medication. If you had an app that facilitated that communication, that probably would be there. So you would actually have increased capacity of your healthcare team as well. We had to interview different stakeholders that would be interested in using a depression app like that. So I talked to several different groups about that, and then we had to come up with a business model. This is something that we didn't get to talk about too much today, but for a lot of different funders, the business model is very critical to say, how are we going to sustain this cost? Because most patients don't want to be charged, and most clinicians don't want to charge their patients. So how are you going to find a way to be able to sustain the cost of that app? The initial part is the most expensive, like building the app, and afterwards you do have to have some maintenance, like a secure database, just kind of any things that you need to modify, with feedback. Okay, and these were the barriers that I think that not just we, but many people came out with: privacy and security. So you have to have really people who are experts at not just security of the app itself, if someone gets in with their password, but also where you're storing your information. How much encryption is there at that database? So you want it to be kind of really clear that that's the case. And HIPAA has some rules about that as well. We knew that we couldn't have a database that's stored in America. We couldn't have a cloud-based database. So there's all these rules having to associate with your institution about that. There was not necessarily, like we talked about, I think someone talked about this, about lack of reimbursement, that a lot of clinicians' time is not paid, physician time is not paid. Actually, in BC, you can get paid for some procedures related to, doing e-mental health, but a lot of reimbursement doesn't exist. But if you get people who are salaried, then it's not really, so much of an issue. But for physicians that are reimbursement or procedure-based, you have to find a mechanism that incents them to do it, because we talked a lot about the risk the clinician takes, like having to see these reports at maybe 3 o'clock in the morning the person feels suicidal, having to balance those two things between the clinician using the app and not wanting to use the app, balancing those types of things, because we do that in general. If you're on call, you get a kind of a surplus or some kind of added amount that time. So you have to incent the people that the clients want to have contact with them to use the app, to really show to the clinician that this is actually going to be helpful for your whole patient kind of population in general. Some people do not have connectivity. Not everyone has a massive data plan all the time they can have access to all the time. So some people don't have connectivity. A workflow change. So within your institution, there will be a workflow change. There will be, we thought we're going to have a psych nurse that looks at all the requests from the evening before in the morning. So we'd have to change what she would be doing in the morning and have her have time to be able to speak to the healthcare clinicians, on her team. So workflow change occurs as well. It can be very expensive. The startup cost can be very expensive, up to sometimes they estimate $500,000. So it can be very expensive at the beginning. And sometimes there's not enough information for you to make an implementation change kind of thing. You have to really get buy-in. But sometimes you really want to be able to show, using pilot information, pilot data, whether this is actually going to be helpful for your patient. If it's going to be increasing a lot of patient visits at the beginning, the clinicians may not find that useful. But overall, if they're going back to work, if they're going back to school, if you're demonstrating those things in a longer term, that's very, very useful. But so you have to kind of collect the information, not just be a very interesting idea, but actually demonstrate it in a way that's convincing to your healthcare, your administrators, hiring someone that just does that. So you really want to have convincing information about that. Hospitals in general are very, very traditional, I would say, very traditional in large institutions, and so they're not light and agile institutions that want to change very quickly. So oftentimes the hospital doesn't change it, but a department or a group can change it and demonstrate that the small success can be a larger one. And it does on the surface seem rather complicated when you talk about all the different stakeholders involved, the programming team, the marketing team, the project manager. It seems rather complicated at the beginning. And there really isn't a lot of evidence for all those apps that are initially where you have to pay, the commercially ones. There's not a lot of evidence to say those are actually helpful. There's a lot of research that's being done for those, but that's why if it's generally kind of expert driven by a clinician or a user group, that would be better. So there's a big niche in that part of it in terms of having real evidence-based apps. And there's really right now a lack of sufficient information. So I had learned, and I think that we're all learning along, that it's really uncharted territory. We really don't know sometimes where we're going. There's some roadmaps, but it's not very clear. It really requires a multidisciplinary approach. You need a lot of people, a lot of experts available, and it really requires that even more so than just the treatment team. It involves a lot of other experts. It takes a lot of patience and time. Programming something to be like you, because you do something very complex, is not an easy thing. You think, oh, this is going to be really simplified for me to do. But just like, when you see David's kind of, theory, it's not easy to be able to like get something to be able to mimic you. It's very difficult to do that. You need to involve users at every stage, and you have to have very clear communications about the objectives. You have to say, at this phase, we want you to answer about this. We're going to address this other part later, but this part, we want you to do this. And that really sets proper expectations about what the client is going to, receive as well. And you need to get your experts in web development, graphic design, user experience, subject matter expertise. And I said this already, there's no standards out there. It's Wild West territory. And so it's important for you to take these kinds of things into consideration in order to get kind of good buy-in and to be able to prove that your app is really delivering what you designed it for. And I think that's it. Oh, well, essentially what's in store, I want to say that if you really use technology correct, I really think that it's really unbelievable what technology can provide. You just have to kind of guide it correctly. And these were just like possibilities for things when we were talking about brainstorming about mental health, tools. Okay.